So I need not repeat these things. The only thing that I would like to tell you is, it's very, very important you remember this name of Gulfstrand, because he's the only person who has got Nobel Prize in ophthalmology. After that, till now, clinical people have not been getting Nobel Prizes. It's always usually the basic sciences people. So this is a very, very unique thing for ophthalmology, to remember that. And techniques, she has already told you that these are the techniques. What I usually tell is the techniques are a lot. It's like ABCD. All you have to know, first initially 1 year, everybody will say ABCD, ABCD. We are teaching a child. But afterwards, we are never using it in that order. We are not saying ABCD when we are meeting each other, right? You have to make BAT, BAT, CAT, CAT by changing the order. But to understand how to do it, you have to know which is A, which is B. So that's the reason that knowing these things is very important, and that's why to begin with I say go in an order, and when you are seeing, just make sure that you are doing it and you are getting it. So I know A, I know B. Now when you see a patient, in this patient because of these symptoms, I will directly go to this technique. That will come later. But initially to do all techniques in your friends, and then so that in patients you don't spend so much time. How many of you have sat as a patient for a slit lamp? Have all of you experienced slit lamp on yourself? Okay? So that's important, because that's when you do it is when you will realize that what is the brightness of the light, how it hits you, and how much difficult it is to, stay like that. And when you're saying don't move, don't do this. And all of you, all young people with no other problems, imagine with all that 70, 80-year-olds, you are saying don't move, sit like this. So first thing, diffuse. So this is the order I'm going to tell. I'll tell you later why that's important. So diffuse, she's already told you that. Dimensions have to be full height and width, diffuse. 5 things in each technique. 5 techniques and 5 in each. 5 into 5, 25 ka table and your slit lamp is done. Okay? So the intensity has to be moderate to maximum, but start from a low intensity. You don't really need high intensity because you are making the beam bigger. Angle can be anything. When I say anything, that's why we come to 45 degrees, which is usually we move between 30 to 60 because that's the most convenient, so that we don't hit the nose and so that it doesn't go away from what we want to see. So if it is the right eye of the patient, it is 45 degrees here, left eye is going to be here. Okay? Then the magnification is low because we are seeing overall everything. We don't want high magnification. Special features is that there's a diffuser which is on. So for each of the technique, I want you to remember 5 points like this. Okay? So now you tell me what are you seeing? One person. One video will start playing. So there's nothing but clips here. Ma'am,
we are seeing a patient in diffuse illumination by through a cobalt blue filter.
Showing some amount of fluorescence staining, irregular, some SPKs. Yes. Okay, so that's the way you start answering that we are seeing a color slit lamp photograph, like, video, which is showing us like that. Okay? So all these things are what I made some 15 years before things. So these are all my LVP patient videos. So somebody else can describe the other one. Next. So this time we will skip all that slit lamp photo, blah, blah, blah thing for every time. But this is how you should do. In your Viva Voice especially, it comes handy. So that it gives you time to look at the thing by the time you're saying that.
Ma'am, this is diffuse illumination, yellow filter, and it looks like a near total cataract.
Okay. Fine. Remember this. Okay, diffuse he said, and he said it's a near total cataract. I'll come back to that. Next one.
This is a diffuse illumination seen through a red-free filter, the cornea.
So showing us some, so red-free when it is there, so it will show us much better for the with staining.
Oh.
Rose Bengal, you will see better. So some kind of thing which is showing, not very, just wanted to show the filters here, okay? So what all do you see in the diffuse illumination when you see? Which are all the things that you are seeing? That parts of the eye that we are examining is the eyelashes, okay? The lid margin. We are looking at the meibomian orifices. We are looking at the conjunctiva, which includes upper tarsal, lower tarsal, and bulbar conjunctiva, right? And overall of the thing. So, okay? So we miss it. Quite sometimes we can miss a BCL, which is if you have not seen the diffuse. Okay, and if you go ahead and put off a fluorescein on a patient who's using a soft contact lens, and then they say, oh, I'm wearing the lens, and now that's stained permanently. So it's like, and it doesn't show very good if your ophthalmologist doesn't recognize the lens and then stains it off for the patient, right? So obviously, so make sure that you're seeing that. And we still have to come back to the other things which were told. So in diffuse, are we looking at the lens? You told me that was a cataract. So in diffuse, are we looking at the lens? So basically in diffuse, we don't know where is that. We know something is white. We don't know the depth. Okay? So I'll come to that. That's why I said I'll show you that same thing with the depth. So now this is sclerotic scatter. Coming to the next one. Dimensions are full length and 1 millimeter width. This is what we call a rectangle, which is like easy. The most commonly what we use is called a parallelepiped, the way we use. But intensity of the light is maximum. She had shown a very beautiful picture of the sclerotic being there. Angle, again, keep it at 45 degrees. Magnification, keep it low. Special feature is that it has to be offset. This is not the technique of the normal slit lamp. You are illuminating some other place, you are looking at some other place. Otherwise, you are supposed to look at the both places. The principle of a slit lamp says, she told you, it's the same place illumination, same place you are seeing. Whereas here, we are offsetting it. So there is one more thing in the beam where you can just slightly offset it. So that the illumination, and if you are looking like this, the illumination is not going the same way. But sometimes, rather than that, if you offset it and you go out of the room and somebody else is trying to see, they'll be struggling that I'm not able to focus the lens properly. So that's why instead of changing it like that, the easy thing is for you to look from the outside. So your intense light is going, but if you change your observation, so basically your observation is going from the other side. So in a sclerotic scatter, that's what is the simplest thing to do. So you are going to see its total internal reflection, and what Simi told you was correct, that it's going and you are illuminating the temporal limbus, but you are not looking at the limbus at all. The light is going like that, you are looking at the cornea. So this is your patient, the cataract that you said, the first one. So now what would you want to change that once again? What is it now? It comes back to you. Things will haunt you. But now what can you say now? That white, you saw something white, you said it looks like a near total cataract because you thought the whiteness was in the lens. Yeah. But from a diffuse point of view, it need not be the lens, it's on the cornea. Because sclerotic scatter, now do you see the lens? No. So sclerotic scatter doesn't show you anything inside the cornea. So what is happening in a sclerotic scatter is the cornea is like this. The light is going like this, and if you people have known that diagram of drawing it, right, and coming out here, okay? So please make these small line diagrams in your exam papers. It doesn't take you hardly 30 seconds to draw one cornea like this and one going here, one coming out here. So when we are correcting the papers, let's say we or any examiner, the moment I see one small thing like that, I like, okay, I don't have to really read through all that thing that you have written. So that's how you have to save your time, convey to the examiner that you know this. That's the whole part of it. Because more or less by 3 years, everybody has gone through the whole thing. Okay? But then the thing is that if you do that, you know the principle, total internal reflection underline, that we know, okay, fine, this is done. Okay? So the normal cornea will appear black because there is nothing to see there, because their arrangement is very, very regular. So there is no scattering of light. Whenever there is a scar, it will scatter the light. Okay? Now the mic goes back to Megha, because this was her thing. So now what can you tell me about the... These are not... this is video. So just that the corneal opacity, again, you're confirming it's on the cornea only.
Yes, ma'am.
Okay? Anything else you are seeing, or you are fine with that much? So does this technique give us anything else? No. It will just tell me where I should go and focus my direct focal. Are you getting this? That's the reason to do it next. Diffuse, overall, you saw the lids. Then you do sclerotic scatter, which is the same, nothing but a parallelepiped. But instead of directly jumping onto the cornea, keep it onto the side. Just look. It is showing you whether there is actually something or not. If it shows you one thing, something which is not to be there, then I go with my direct focal onto that. Okay? So direct focal, again in this some 3 subparts. Parallelopiped, which is full length 1 millimeter. Optic section, lengthwise you make it the thinnest and the height remains the same. And the conical beam the opposite, 1 millimeter, the height you make it so that it becomes small. Okay? So we just go for with each of these things. Parallelopiped dimension is the same. Intensity moderate to maximum because now we are going to the thing. Angle again we can keep changing. Magnification low to moderate again. We are not going to very high. Special feature is as I tell, please remove the offset setting if you have done it for the sclerotic scatter. Okay? And so this is the same thing which we are seeing from here to there. So this is what we say oscillatory thing. So again, that oscillatory technique is not anything separate, but we do this all the time, no? We go from here to there. Then because the nose will come here, so we'll change it and then we'll do. So make sure that when you're going from right eye to left eye also, always please pull back the slit lamp and then go again. You're not going like this, okay? So I don't think there was anything there, the other parts. So the cornea, in this what all are you going to see? So in the cornea, we are going to see whatever is the point of interest. Okay, so there is something white or something black or whatever. But so white can be scar, it can be edema, it can be infiltrate. Mainly white is all 3 things. And during your course is how you learn to say which is which. And any foreign body, obviously, if that is more obvious. Iris, then you go inside. Now you are focusing direct focal onto the iris. You see the pattern. You see your crypt struffs. You see the nevus. You see any NVI. You see pseudo exfoliation. You see all these findings there. Material there. Pupil details. Again, you can see with this also instead of the diffuse. That, pupillary rough. Sometimes when you reduce the intensity, increase the intensity, in trauma patients especially, you will see the 2 o'clock to 7 o'clock will contract and 7 to 2 is like not. So maybe there is a pupillary damage, sphincter damage on one side. So it will be like sluggish here. This is not happening, something like that. Or any posterior synechiae, you have not yet dilated, but that area it is showing that it's not happening. So when you dilate, you will get a festooned pupil. So that part you will see. Then you can go with this onto the anterior lens capsule. When you focus it into the nucleus, you can see sutures, the Y-shaped sutures, not the sutures that you take, but okay. And the posterior capsule, in this you can see the extent of a posterior subcapsular cataract. So when you say overall, if this is 100%, this is 30%, 50%, 70%, that how much of amount is what you are seeing when you are seeing with this. Okay? So with optic section, we are going to the next one. So in this, what all we are doing is, as I told you, everything else is same, but we are making it into the thinnest possible thing. And so we have to make the intensity maximum because it's such a thin beam that if you don't keep high intensity, you will not get an actual correct picture. Again, angle changes, magnification changes. And this is the thing which makes being an ophthalmologist as rewarding as it is. Because you can cut through a living tissue without doing surgery with this. Okay? Till now, the only people who can tell about that is, excuse me, poet. Oh. So, ningi irkuno nadi. So, because till now only pathologists were making sections. Whereas now in a living section, we are making a section, right? Living person without cutting across. So this we come back to you again, I think. So this is the same case. Okay? So now we say we are seeing a corneal scar, which is, now we are saying what depth in the cornea also. And each scar need not be the same depth throughout. Now this is, that's the reason I'm moving it. If you see at one point it will be only anterior stromal, one point it can be full thickness, the other point it can be just posterior, right? So then, in fact, when you're drawing your diagram, you are supposed to draw one line which is showing you that this is cut section from here, make an arrow mark, draw a section and draw. Then the middle part, another thing, draw again another side, so that you are actually showing me that, okay, middle it is like this and for your own understanding, okay? So it's a diffuse scar with varying thicknesses, That's what is your case. So the next one. There, ma'am, this is for you. This is yours. So if you have missed to see the BCL in the diffuse, when you make a slit, you should see the BCL. Okay? Because this you cannot miss, because you have to make a section in every patient and see. Diffuse we may not do for every patient. We may be in a hurry to go to that actual thing what we are saying, but you have to make this. Normally you will see 3 lines, you don't see 6 lines of the cornea, but here at one point, I hope your people are seeing the extra line which is there. Can you see that now? At one point that focus comes correctly. Okay? So then you say, oh yeah, since when are you wearing contact lenses? And you act as if you saw the contact lens long time back. Okay? So in the cornea you will see the depth of the lesion. That is the most important thing. Second thing is you will see the contour and you will see the thickening, which is like, and you will see the thinning if it is a scar. So as I told you, whether it's a scar, whether it's edema, whether it's infiltrate, you have to learn. But when you make the slit, this is what is telling you. If it is a scar, scar is fibrovascular, it will pull it together, so the slit is becoming thinner. Whereas edema, it is becoming thicker. So you have to see normal corneas. That's what I was trying to show you today, that you have to see each other multiple times and see that normal cornea, how it is going. So you can't really make out that the center is thinner and the periphery is thicker that much. So it looks like 2 parallel lines, okay, for the normal cornea. Whereas when it's like this, then you can make out that it's obviously different. So this is Megha yours again. So this was the patient which you saw, right? And you saw it was keratoconus. So you can make out that the ectasia is there, but keratoconus, what should be there normally? But what is there right now? Thicker. So in a keratoconus, center is thicker when? What is it called? First years preferably. No. Okay. Hydrops. Okay, so there is a Descemet's break. So the water has gushed in. The AC aqueous has gushed in and it's a corneal edema in a keratoconus ectasia, which is an acute hydrops. So normally keratoconus ectasia, I need to see thinning. I'm seeing thickening. That thickening like a sausage you can see very easily, right? It's a very severe hydrops. So now coming to the conical beam. So in this you have to make the opposite. The width remains the same. The height is like made smaller. Intensity again, whenever we are going into thin and small things, maximum. Angle again we change. Moderate to high because it's very, very small beam that you are trying to see. And the special feature is you are going to see the AC in this to see the cells and flare. So how do you focus on the AC? Yeah, so basically focus on the cornea, then move and focus on to the iris or the lens, depending on dilated or not dilated. Then you come in between, come front in such a way that both is a not focus. You understand? Because ideally it is supposed to be transparent, invisible. So if you are supposed to focus on the invisible person in this room, then you don't know where to focus, right? But if I tell you it is between these 2 people, so I have to focus here, then move and focus there, then move in such a way that now I am in between these 2 without, so I am looking at that point. And if it is clear, then fine. If you are seeing things in that, you need to wake up people. Huh? And then in that thing, when you say 10 cells, 20 cells, 30 cells, which is what the grading gives you. So are these cells in the whole of the AC? So in that particular thing, when you put that field, how many are coming for you? Because they are moving, right? And what's the movement? Yeah, and yeah, so how do the cells move? One person. Yeah, convection current. So what is the direction? How do they move? How does it move? So up where, down where? This is fine. Cornea. And why? Okay, iris, blood vessels, warmer, goes up, goes front, cornea, no blood vessels, comes down. So So only when you have a few patients who have iridocyclitis cells can you see this movement. Because normally you can't see anything in that. So that's why whenever next you see a patient who has uveitis, then please see this movement if that's happening. Okay. So the flare and cells is what you see in that. It's very difficult to show, so that there's no video to show you. And now that we have seen this, the thing is to go into indirect or retroillumination. So that can be from the iris when it's undilated and from the fundus from when it is dilated. So there are, again, you can just make it direct retro, indirect retro and marginal. Not much of a difference, maybe half a millimeter here, there when you are moving. Direct retro is when I'm directly looking at this and the behind thing is actually coming and focusing. Indirect is it's like direct is if I'm focusing on him and the light is going to you and coming direct. Whereas indirect is, as I said, that invisible person in between, the light is going from this and coming. So the light is not in my path and I'm seeing the thing between. Marginal is that edge when you're moving it. So practically not much of a difference. But yes, sometimes to add one point you can write. And so this is somebody who has not yet answered maybe. The first video. The behind people are still there, no? Who have to answer? Huh? I mean, take up the what can you see type. So it's obviously in retro from the iris. And when you see retro from the iris, what will you see? Which part are you seeing? Cornea only, right? Or anterior chamber if there is any glass foreign body or something like that. But you can only see the things which are in front. So from retro from the iris is only cornea. So that's a big bulla there. Bulle you will see, and then see if you see there's one thing, and if it is getting illuminated, then high magnification it will change. So that you are able to see that elongated one bulla kind of a thing. Okay? And the next one is retro from the fundus, which is showing. So we come back to you. That is your case. So now can you tell me anything?
We can see the fundus more.
Too much here. So the thing being that then if that this should be a railroad track kind of a thing. If it's blood vessels, two things together going and blood would have got absorbed. So ghost vessels will have two lines. So this is only single lines, crisscross, and too much, and this was not vascularization, this was not nerves, like when you saw it was a scar. So it was an advanced lattice dystrophy which had led to scar. So lattice the patient may not come at a time when there are only lattices there. They'll come at a time when it is, gone to that kind of a thing. But by the time you finish your examination, you should have actually reached a diagnosis which is actually telling you this is lattice advanced. So sometimes what can happen is one patient may be like this, the other eye may have a PK done. So that will be your clinical case. Once PK done, you cannot say why it was done when you are seeing the patient. 15-minute short case. You understand? But your examination is not complete till you see both eyes. So if I come and stop you and say, okay, now tell me what is your case, and if you have only examined one eye, and if you say, I have not examined the other eye, I need 2 minutes to see the other eye, it is better, like then I'll say, okay, this person knows what they're doing again. Okay? But that doesn't mean another 15 minutes you take for that. And in those 15 minutes, if you have been given, you should be seeing the other eye also. You should just glance at it and come. Now that will say, this is, other eye is a keratoplasty, the eye, right eye is your case. But on examining left eye, I saw that there was lattice, so I can say that this is done for dystrophy. Okay? So this must be an optical keratoplasty done for a dystrophy, like that. So retroillumination, doing it is a full length 1 millimeter width, like the parallelopiped only, moderate to maximum, again this can keep changing. You have to offset for iris, you have to understand the iris light is going somewhere, whereas it's going to be coaxial for the fundus 90 degrees which you keep it. Okay. Now retroillumination, what all can you see? As I said, showing you cornea, you can see microcystic epithelial edema, bulle, which you may have missed earlier. Deep vascularization you will see. You will see ghost vessels, lattice, In iris, when you are doing it without dilatation, you will see an atrophy or a hole or a patency of the PI. In lens, you will see the density of the cataract. So when you put it, when that becomes like, side is more red and then it is not. So that is, if you don't have a corneal scar, then this is the intensity of the cataract. So basically your indirect light when you put and when you see, or your direct ophthalmoscope when you see. So that much is what the patient is getting troubled by the cataract. Okay, because our indirect and all are so bright light that we can actually see the fundus and all even in NS3, NS4. But the dullness of this is what tells you what it is. I think this is a retro from the fundus showing. Anybody? Next person showing what? The pattern wise, some black spaces. So that again, when you are moving it, you will be able to see better than what you are seeing it, okay? And now come to specular to actually go and see those guttae or the thing. So in this, you are going to make it like a parallelepiped, but make it small, 3 to 4 millimeters. So the intensity has to be maximum. But first, I would say start with a lesser intensity. Angle 60 degrees is what helps you. You can make it different, but 60 degrees is that it goes and you are going to see the thing. So magnification, first start with low magnification, then go to high. Special feature here is what was the technique of this again? Specular is based on? Yeah, direct, but what? Specular is what are you using? The technique is what? Yeah, so angle of this thing is equal to the angle of reflection, right? So for that, for you to have it like that, if you keep it somewhere else, then it will be different. So if you keep it at 60, then it goes like this, comes like this. So it's easy for you to see from the center. And it's uniocular. So this angle can happen only with one eye. Again, see, if something is coming from here to my this eye to my this eye, the angle changes. So if you want it to come like this and come angle at that angle, I can only keep one of my eye there. Okay, so that's important. So if I say see specular and if you are trying to see with both eyes and trying to tell me, so either you can close or you can just come like that to that one and say in which one are you going to see. So there is Purkinje images are there. How many? So the first two are on epithelium and endothelium. So you have to focus your light and mix the light and the Purkinje image, make them coincide, and there's a dazzle which hits your eye. Dazzle hits the patient's eye also. Okay, actually when you sit and get your friends to do it, you will know that they have reached that point. So there is a dazzle. It's like the dazzle which comes when you are driving and there is like the mirage. So at that point, so when you go closer, you can't see that, right? So it's only at that angle. So you will get that reflection, a dazzle. At that point, make it higher and go slightly inside because you may have got the dazzle from the epithelium wala Purkinje. So now go slightly inside so that it's the endothelium and then in higher magnification and you see the endothelium. Can you see it there? So if you are going from the left side, it will going to be on the right part of your beam because this is cutting through epithelium, stroma, and then only the right part will have the endothelium or the other way around. So you have to focus onto the other side. How many of you have seen endothelium? Hopefully the people posted with me should have seen. I don't think I showed you. Okay. So please, tomorrow at least. Today now everybody is too sleepy, I think, and time is over. So I'm not going to go tell you to go today, but tomorrow catch hold of your friend and make sure that everybody is seeing it. At least the people who are here have to see the endothelium in each other. Make sure that you are seeing it in one or two people so that it's not just a fluke that you are getting it. Okay. So it will look like all of you who have used slit lamps, you have seen, okay? So it will be like a nicely sharpened pencil if you are drawing round circles, keeping it like at this distance. You can see that it's nice pattern. So that's how you will see it. You will not see 6 sides, but you will see that there is a good pattern. See, now I'm seeing like this, so I see there's a good pattern of seats, right? Suddenly if one seat is removed, So when you look overall, I can just make out that there is a space in between. So that's how the gutte look. So otherwise, I don't have to see each seat whether everything is okay or not, but just a glance tells me this is uniform. Okay? So the dilated examination, you have to come back to slit lamp. That's very, very important, because after you do all this is when you do your applanation, when you do your gonioscopy. I'm not going into that detail. And then you dilate the patient, provided your angle is deep enough, which you have checked with your optic section, placed at 60 degrees. Because again, if you keep changing, it changes. So Van Herrick is done at 60 degrees, and then to see that, and then come back and do repeat slit lamp as I told you, from the fundus, so that you see any of the things. Evaluate your lens, because then only you will see the difference between your PSC and PPC, because it's now dilated. And now go with optic section. If you see a clear space between that opacity, then only it's a PSC. If you think it is flushed with it, then PPC. Or make a note, if you're not sure also, always keep thinking it's PPC. You understand? So query PPC. So when you're writing on your notes, somebody else may be operating, but like the query PPC component will make it at least, they'll be more cautious. Better to be erring on the edge of being PPC than the other way. And obviously fundus, then you place your 90D, 78DA, and you are going to see the thing, okay? So till you do all this, the slit lamp part is not over. Indirect is a different thing altogether. And then you are coming to your clinical, diagnosis by doing all these things along with history. That part we didn't cover today. We covered only slit lamp. So the first history, then the history is telling you patient has itching and you have everted, you have seen papillae, rest everything okay. So your clinical diagnosis, this is allergic conjunctivitis, something like that. Discharge, whether you have seen or not, so infective. So depending on your provisional diagnosis, which is based on your observation, then your interpretation of that observation, then any differential diagnosis. It can be viral conjunctivitis also, allergy, viral, it can be those. So if you want to send for some investigation, if it is like going to be there. But if it is not so much of a difference, not everything needs an investigation. But suppose you see with this and you put 90D and then you see there is a 0.9 cupping, or whatever, or a disc suspect. So then you send for fields, like that, okay? Based on which you make the final diagnosis. Once you reach final diagnosis, things are simple. See, in your mind, if you have decided this patient has angle closure glaucoma or a shallow AC. So what to do in shallow AC is written in your book. Hopefully, if you read your book, okay? So it is written, shallow AC, you have to do YAG PA, if it is this, you have to do this, you have to do this. And open angle, you don't do YAG, you have to give eye pressure related. But if your distinction is wrong, if you are looking at a shallow AC and thinking it's open angle, and you are treating it like that, you understand? Things go wrong when you are, because book is telling you both the things, but which one are you following depends on what you are seeing and thinking and interpreting it, okay? So when you do these things, that's why the reading the books is important, because once you reach here, you should then further know what to be done. But for reaching here, only books will not help you. You have to do this, and 50 patients, you have to see what is normal. Then you start, seeing that this is abnormal. This corneal curvature, oh, this looks a little different. Like that, to observe that, okay? So that's the reason that to study the phenomena of disease, I keep repeating this for everybody. Without books is to sail in an uncharted sea. So if you are at least lucky, you will think you are going to India and you will go to America and discover a new land types. Okay? But you will reach somewhere if you are at least seeing patients. But if you are sitting in a library and reading and not seeing patients, it's to study books without going in the ship at all, which is not going to help you at all. So patient care is the most important, and that's what you need to do, coupled with what you are studying. Okay? We'll end it with that. Okay? Any doubts? Anything you want to clear? Or everybody is very clear?